Yeah. Good evening, everyone. Good evening, Dr. Bhattacharya and all the elders over here. Dr.
Thank you.
Lakshmi. Yeah. It's a pleasure being here as a judge for this particular program. And last time we had two teams participating. One is the AIMS Rishikesh, the other one is the Central Hospital Southeastern Railway, Kolkata. So there was a fierce fight between these two. Both of them have done extremely well. And there was a unanimity amongst the judges' opinion. And the Central Hospital South Eastern Railway, Kolkata, emerged as the winners, and they'll be going to the next round. Dr. Lakshmi, you can start the program. Central Hospital, Southeastern Railway, Kolkata were the winners last time.
Okay, congratulations, team Central Hospital Southeastern Railway. Now, I would like to start our sessions, sixth session and the last session of this Plastiquest challenge in Burns. Today, we have our four panelists. Dr. Smita ma'am will be joining us shortly in half an hour, sir. She is a professor at Bangalore Medical College, and Deviprasad Mahapatra, sir, who is well known, a professor in Jipmer, Pondicherry, and Elia Sir actually is going to join shortly, sir. He will take some time. He is a professor in Kilpauk Medical College, Chennai, and our very own Umar Farooq Baba, sir, from SKIMS. And to moderate this session, I would like to invite Dr. G. Karthikeyan, sir, the well-known personality in plastic surgery. So first it is team 1, KGMU. You have 10 minutes for this spotter. Your first spotter is this. I would like to request Devi Prasad Mahapatra, sir, and Smita Sagu ma'am is not there. So I would like to request Bhattacharya, sir, to just lead the questions. Team KGMU?
Yes.
Okay. Bhattacharya, sir, you want to give a brief history?
So, what do you think this picture shows? What is your diagnosis?
This is a high voltage electric one involving the flexor and extensor aspect of the distal forearm and hands.
Why do you say it is high voltage?
Because of the gangrenous changes that seen in the distal fingers.
What is the criteria? High voltage, low voltage?
So if it is greater than 1000 volt, then it is called a high voltage electric one, and below this is low voltage.
How does it matter?
So more the voltage, more is the damage to the more deeper is the damage to the tissues.
Sir, take over, sir.
So, do you think any changes are there following this electrical part?
Yes, sir. The fingers
what are the changes?
The skin discoloration is there, and due to high voltage electric current, there is flexor contracture of the fingers, and also we can see there is cyanosis of the nails, also suggesting distal necrosis of the hands and the fingers of the hand and the fingers.
Will you call it cyanosis?
No, sir. Early gangrenous changes.
Early gangrenous changes. So, how do you define early gangrenous changes?
Sir,
I mean, what has happened to it? Why do you utter the word gangrene?
So because there is macroscopic changes, we can see the distal tip have gone into necrosis, sir. There is charring of the fingers.
What do you think would have been the mechanism?
Sir, we compartment in the limb because of the edema. Sir.
No. What I'm asking is that what is the mechanism by which this accident might have happened?
Sir, contact with high voltage electric line.
So what it has caused? What is the mechanism of the tissue injury following high voltage electrical injury? What is the mechanism?
Sir, there will be involvement of the microvascular circulation, as well as the limb occupy the position of ease. So there will be edema in the limb also. And due to the divide of circulation, it will lead to the gangrenous changes.
Okay. So when a current passes through tissues, which is the least path of resistance?
The bone is high resistance. Is high resistant, and so the muscle, nerve and muscles are the least resistant.
The other team?
Sir, bone
Osmania?
gives very high resistance to the current, sir. So hence, the tissue surrounding the bone is damaged more because of the
I asked what is the least path of resistance?
nerve, sir.
Sure? Dr. Mahapatra?
Yeah. So on the image, you can see some incision lines on the dorsal surface and on the lateral surface. What do you think that could have been? Can you see the image on the distal forearm? There are some incision lines, sort of thing, na? What are the,
Ascarotomy is done in lateral surface.
sorry?
Over the dorsum as well as in lateral surface of the forearm, sir. Ascarotomy might be done, sir.
Escharotomy, or do you think something else?
Yes, yes. It is not reached till the fascia.
Okay. When this patient comes to emergency, what assessment you will do?
We will start from the airway, then we'll check for the breathing and circulation. Then if this all is good, then we will focus toward the local sites. And
in this case, it is the hand. So what you will do? What special, how will you evaluate the hand?
first, by inspection, I will check the extent of the bone. Then on palpation, we can check the vascularity of the limb, sensation of the fingers, and
How will you
then
check that?
movement of the fingers.
How will you check the vascularity?
Initially by palpation, palpating the distal pulses, then on by the pinprick also.
Okay, then.
Also, sir, we'll look for the proximal limb, viability of the proximal. Is there any edema or compartment pending compartment syndrome in the proximal limb? And also, I will look for the any exit wounds are present or not, and any other burn injuries, electric burn injuries present in the body.
Okay. So if you have, how do you know compartment syndrome clinically?
There are 5 P's: pain, pallor, paresthesia, paralysis. Out of proportion pain will be there, and out of proportion swelling of the proximal limb distal to the affected limb will be there.
Pain and swelling. Next, after that?
Pallor in the limb. Pulseless.
Pulseless, you'll check the pulse. What else?
Paresthesia.
Paresthesia. How the patient will compare paresthesia?
Sir.
Okay. Now, can you tell me, like, how is electrical burn in this particular, like, hand burn? Electrical burn is different from thermal burn. Electrical contact burn is different from thermal burn. How is the mechanism different?
Sir, in case of hand, sir, the electric current passes to the deeper tissues also, and due to its involvement in the deeper tissue, and in the hand, we have fibro-osseous pulleys and flexor compartment tunnel, which further doesn't dissipate the current injury to the outside tissue, and it remains in the tendon sheath, and it expands proximally also.
And thermal burn?
It is localized to the area which you can see.
What will be the appearance in thermal burn?
Sir, blistering will be there if second degree in partial thickness burn.
It can be partial. Yeah. And
In full thickness, there will be pale waxy appearance of the bones, or in deeper, in full thickness, sir, there will be involvement of the involvement in the dermal, deep to the dermal.
So how will you prognosticate this patient to the attendants?
So the viability of the limb is can be compromised in future, and
So what will you tell them? Answer straight.
sir,
Yes.
we might have to amputate the distal limb, and also proximally we may need to give a fasciotomy incision if required.
Proximally means where?
Sir, in the proximal forearm.
Do you think that the proximal forearm gives the sign of requiring a fasciotomy there in
No,
this
sir,
case?
not here, sir. But if it may be required, if edema further progresses.
How does that help?
Sir, it releases the fascia, so the circulation improves in the limb, and
You see, the forearm is relatively free and the palm is relatively normal looking. Why it is so? And in between two skip lesions, the fingers and the wrist area.
so the palm is connected to the bone by intervening septas. So and due to this more fatty content in the volar side, so it is relatively resistant than the dogs.
So do you do any release in palm also?
In palm, we will open the carpal tunnel.
Decompression?
We will open the carpal tunnel, and
Carpal tunnel. Where is carpal tunnel?
it is in the zone 4.
You can show in your hands where is the carpal tunnel location. How will you give the incision? Direction of the incision? So along
the crease, sir, then zigzag over the wrist.
Camera.
Sir, the time is up, I think. 10 minutes.
The time is up, sir.
Okay.
If any clarifications on these questions, I mean, questions which are not properly answered by the PGs, the panelists can clarify them. I mean, elaborate them in a detailed way if they want to. But Ajay, sir.
I think it has already few days have passed and there is almost a line of demarcation. See, the palmar skin is very thick and many times the skin changes which occur in the normal area like the wrist, around the wrist, you may not be able to see all those signs very early in palmar area. However, one can give a chance because the deeper vessels are there and the decompression can be tried because at any cost we try to save the hand. So we can tell the attendants, and this is how you prognosticate, that we will try to save it. We have to make more decompression in the palm area, but it may not guarantee. The second thing is that it's quite possible in this particular picture that the area which came in contact may be the wrist itself or just distal forearm because that looks to be more charred, So it is quite possible in that. Even then you will find these changes in the fingertips, the gangrenous changes which have occurred. So, and you must also tell that ultimately the patient may require an amputation and followed by prosthesis. This is how you have to tell the attendants, I think.
And when you're
AV
asked, when sir was asking which is the path of least resistance,
Yes.
he kept saying nerve. As you know,
Yes.
electricity passes through water first, isn't it?
Yes, yeah, it is the vessel. See, it
Okay.
passes through. That is why so much of damage. The path of least resistance is the blood. the vessels. So therefore, the damage is maximum to the vessel, and therefore, ultimately, the area which is supplied by those vessels get devitalized.
And when Dr. Devi Prasad was asking about difference between thermal burn and electrical burn, I think none of you mentioned about the iceberg phenomenon. Iceberg phenomenon. What is
Yes.
iceberg phenomenon?
Sir,
You can see that we cannot see which is not being is not
sir, in electric burn
exposed.
injury, the part which is visualized is more. The injury is much deeper because it is affecting the deeper tissues more. So we cannot see which more deeper structures are involved. But from looking from outside, while inspection from outside, it may seem small, but it may be having a huge amount of impact internally.
We are able to see just tip of iceberg.
Yeah, so when you're asked about difference between thermal burn and electrical burn, in thermal burn, what you see is the burn of the skin. The underlying tissues are less involved. Whereas in electrical burn, what you see is only superficial. The deeper tissues are more involved. Why are they more involved?
Sir, again, because the electric current passes through the tissues with relative resistance, and through the first involving the vessels, then tendons, then muscles, tendons, and bones in this.
So that's all right. Why is it that more tissues are involved? Closer to the bone, do you have more involvement or less involvement?
Sir, more involvement will be there.
Why? Why?
Sir, because the bone will allow more resistance to the current. So it will not pass through directly through the bone, but to the underlying surrounding tissues will be more involved.
See,
Sir,
the
one more request to the panelists and moderators. The questions are not answered has to be passed on to the team B also.
Yes.
Okay.
So that is I request to
I
pass
think
on to
so,
the
pass it
team
on.
B.
But madam, this case over, no, 10 minutes only, isn't it?
Actually 15 minutes if you extend moderator time is separately given, and whatever questions not asked first should be passed on to the team B also. If they don't answer, then the answer should be given, sir.
Okay.
Yeah, you have 3 more minutes, Dr. Karthikeyan.
Yeah. Yeah. So you're talking about the iceberg. See, you were talking about the why the injury is more, why the damage is more close to the bone, isn't it? What
Yes.
about the other team? Can you answer this better?
Because the bone offers more resistance, sir. So the heat generation will be more along the bone. So the tissues along the bone will be damaged more.
Yeah. So more resistance, more heat. Correct. That's the answer. More resistance, more heat is generated. So it cooks all the tissues close to the bone. So that is why you get a tip of the iceberg. What you see on the top is very small. Inside, it's more. Yeah, and then what is the Dr. Devi Prasad was asking about compartment syndrome. What is the first sign that you get of impending compartment syndrome?
Pain out of proportion.
Pain?
Pain out of proportion to the.
What is out of proportion?
So pain is out of proportion.
Pain is out of proportion. What is the first sign?
Where is
The other team?
The pain is
Pain on passive extension of the muscles, sir.
Pain on passive extension. Yes, that is most important. Okay.
So if this patient requires a prosthesis, which type of prosthesis will you suggest to them? Is the right hand of a person?
biomechanical prosthesis.
What do you mean by biomechanical? Other team? Osmania team?
If you don't know, say no, please.
No, sir.
Okay. Sir, shall we move to the second quarter, sir? Like we
Yeah.
are.
Wait,
Okay.
Rohit,
Sir. Okay. Sir.
can I just say
Yeah, please,
one
Dr.
minute?
Venkat.
In the regarding the beginning, I want to give some guidelines or remind some guidelines. They are not new, that they can proceed. A couple of points I want to tell. The description, it is you are forgetting that pages. You are forgetting that you are already consultants. You are already MD, MS. So you are thinking somewhere in McCarthy or somewhere like that, and then you are skipping the basics. The thing is, case presentation should be from your K. Das. In MBBS, what you have learned, the descriptions, there it should start. That is one thing, make a point. Second point I want to tell here, at the beginning level, is keep presenting cases, if at all possible, in your department or to your friends. The free flow will come. Technical terminology will come. Otherwise, the terminology you are telling will give you a very bad impression about you, very low impression about you, in spite of your best preparation. So these two tips I want to give. Please go ahead. Over. Thank you.
Okay, sir. Thank you, sir. We are moving to the second spotter, sir. I would like to request Neliapur sir and Umar sir to lead the questions. Bhattacharya sir, brief history.
Yes.
This is a case of. Okay, sir. Bhattacharya sir, you just give a brief history of the case, sir.
Well, this is a case of homicidal chemical burn, about 1 year post burn, and the patient is unable to open the mouth completely, and the adjacent areas are free, and they are of normal texture. This is the basic. Rest, I think the candidates will describe.
Now coming to team KGMU.
Yes.
Yeah.
So
What is the peculiar thing about the chemical burns?
Good
How are
afternoon.
these burns different from the thermal burns which we usually see?
sir, chemical burns cause either coagulative or liquefactive necrosis of the tissue, sir.
Could be due to acidic or alkali.
Alkali
The
burn.
acidic causes the coagulative necrosis and doesn't go much deeper, while alkalis act by saponification and go much deeper. Then it could be due to some inorganic substances like white phosphorus.
Any other, sir?
I mean to say, how are they different?
Dr. Omar, you have to speak close to the mic, I think.
I am not
Your
audible.
voice, you are audible,
Audible?
but low voice. Please talk close to this microphone.
How are the chemical burns different from the thermal burns? Right? What are the characteristics you will see that you can say that this type of burn can be a differential for the chemical? It cannot be a scald, it cannot be a thermal burn.
Sir, in case of chemical burns, if like in this case, if it is homicidal burns, there will be droplets of the chemical which has been coming and which may be seen over other parts of the body. Like here, here the face is involved. It can be seen over the torso or the neck region also, sir. While in thermal burns, it won't be seen, sir. Whether it is scald or not. If scald burn is there in other parts of the torso, there will be either deep dermal burns or superficial dermal burns. There will be blistering and features of thermal burns. But in case of chemical burns, there will be hyperpigmentation will be there in later after the wound is healed, and there will be sign that some chemical liquid has been used.
Okay.
So team, if the question is, answer is not appropriately answered, we can pass it to team B, sir. And Neliapar sir, you want to ask anything, sir?
Yes. What are the parts here affected? Which parts of the face are affected here?
So
Team KGMU.
bilateral cheeks,
Bilateral-
chin,
bilateral
cheeks,
cheek?
chin,
Ah.
chin, lower lip,
Ah.
and
Skin, lower lip?
Sir, bilateral
Chin,
oral
no.
commissure.
Okay, okay. Is there any classifications for facial burns either by acid or any other chemicals? Is there any classification?
Sorry.
Team B.
So as a result of this burn, what has resulted here? What are the parts, how it has affected? What happens to the mouth? What happens to the nose?
Actually, Dr. Neliapar, you were asking about the classification. We were not knowing. Let us ask the other team.
Oh, they're not knowing. Okay.
Team
Then
2. Do you know the
so
classification
if you know
sir
the
is
problem
asking?
only, then you will tell about how we are going to address this problem. Cindy, so what is the most, so okay, microstomia has resulted for this patient, microstomia is here. So how you are going to correct this microstomia?
The type 1 and type 2 classification will be there for the facial burns.
Yeah. What is the type 1? What is the type 2?
Type 1 is only supple, sir. And type 2 is with the scar formation.
It is according to the scar status or suppleness, or according to the parts it's affected. This anterior, posterior, something like that. Okay, leave alone these things. Okay, leave alone these things. As a result, microstomia has happened. How are you going to correct this?
We will go with a commissuroplasty.
By? You will straight away go for surgical procedure? Is there any non-surgical procedures possible?
Mouth opening exercises using ice cream.
Pardon?
Mouth opening
louder. Mouth opening?
Louder.
Exercises.
By exercise. Any splints possible? Splint.
Actually, how can you prevent the microstomia? Are there any ways you can prevent it? You can stop it so that temporarily it cannot progress more.
Surrounding hypertrophic scar should be corrected by using silicone or compression garment so that the scar gets supple and it will cause least tension over the lips. So the microstomia can be corrected to an extent. Or if not getting corrected by the conservative method, then we should go for the commissuroplasty.
Commissuroplasty.
What is the definition of microstomia? How will you define microstomia?
Less than 2.
Team B.
Less than 2.
Border of the mouth will be less than the lateral border of the nose, lower border.
More.
Why don't you split the word microstomia?
Smaller.
Where are the angles located normally?
Normally, it is located at the level of the pupillary
KGMU
line.
team, primary team, KGMU team. Where is the angle of mouth located normally, which we take as a reference?
So the mid-pupillary lines, straight clicking.
Why do we treat microstomia? What are the indications of operation?
So there is decreased mouth opening, and also patient is unable to feed himself orally, and progressive progressive scarring would also lead further decrease in mouth opening.
Now, what is the adequate? Now, question arises. Then, what is the adequate mouth opening? Because microstomia, you are not telling both the teams.
Sir, less than 4 centimeter is called as microstomia, sir.
Less than 4 centimeters, or anything rough guide. Team
Lateral.
KGMU team first.
Sir, if it is medial to the ella.
Team Osmania?
Not opening.
4 fingers, otherwise we can tell the 4 fingers of the patient. Patient is able to keep 4 fingers.
That will be too much. You
2
imagine
fingers.
your 4 fingers. My
horizontal.
Boy, it will be too much, too much.
What are the sequel? This team Osmania. What is the team? What
team
is the
KGMU, sir? KGMU team.
KGMU? What is the sequelae? He told the patient will not eat properly and other things. So what will it result in?
So patient will end up into malnutrition if we prolong
malnutrition.
underfeeding is there.
Okay. Then
second.
And sir, further scarring would further reduce the opening if we if the scarring is not if it is progressive.
Lower lip atrophy.
So what is
can develop?
Okay, what will it result in? What will it result in? One is malnutrition, he told. What are the other complications come out of microstomia?
So will not be difficulty in intubation and
intubation for surgeon, for anesthetist.
Not daily work, daily course and all that. What can get affected?
So poor oral hygiene, sir. Patient will have very poor oral hygiene, and teeth can be teeth caries can develop, and patient have teeth damage.
Difficulty in articulation parts.
Yeah, speech difficulties. Speech difficulties. Then he told it will progress to much smaller microstomias. So what it will result in?
Sir, time limits.
Huh?
We are crossing the time limits.
Right, Rohit.
You can answer all the questions which are not answered by both teams, sir.
Okay. So finally, it's also that team Usmania. Can you tell what are the other complications apart from this malnutrition and difficulty in articulation and
the time is up for asking questions, sir.
What are the other things?
Sir.
That they couldn't maintain the proper oral hygiene, sir. That may lead into infections.
Okay.
And bad breath.
Okay, all other things. What is the important role for a plastic surgeon? What do our specialties made for? Does not will have cosmetic implications? Okay, it became a cosmetic problem also. Then, sir.
Yes, KGMU. Can you tell me, KGMU, how this patient is different from other chemical burns? Is this a classical picture of a chemical burn? What do you expect more in chemical burn? Which usually happens, which is not there in this particular case. And then why?
Sir, most common cause of chemical burn is vitriolized, sir. So usually it will involve whole of the face, involving the eyelids also, sir.
Even ocular involvement will be
So
more.
if you look at this scar, what more we would have expected in this scar? This is a precise scar, isn't it? Causing the microstomia. In chemical burn, what usually happens apart from precise scar? A liquid is thrown on the face. What happens?
It will fall onto the neck or shoulder, or it will fall onto the chest, sir. You will have multiple burns over the neck also, neck and chest, sir, and your chest fall also. Patient will be having small drop burns. Like.
Sorry to interrupt, sir. Actually, KGMU team, because of some
they are supposed to, and we have to clarify the other questions.
They got logged out, sir, suddenly. They are logging again.
Okay.
Some technical glitch, I think. That's why they are not able to answer it.
Yes. We'll wait. Let them log in.
Yeah, they log in.
Yes. Yes, team from KGMU.
Yes.
I asked that why this scar is not typical of chemical burn, which is usually seen. What do you see in chemical burn, apart from this scar and microstomia? What else you expect?
Sir, it involves the distant region where it is spilled, like the neck or in trunk also, as well as the dripping sign we can see.
So what will you see? What will be the scar look like?
Sir, it would look, there will be feature of a droplet like hyperpigmented wound will be there in the distant side, either in the neck or the torso.
Yes. So why that has not happened in this? There is a trickling of
yes,
liquid.
Sir, there's trickling of the
around. Okay.
chemical.
So why it has not happened? Any idea?
Sir, patient might have applied some chemical compound as a cosmetic or something like that, sir.
No. That has not happened. Patient has not used any cosmetics or anything. That will not make the microstomia disappear.
So patient might have ingested something, then something might have followed over his surrounding cheeks while ingestion.
See, chemical burn can happen, a liquid chemical burn or a powdered chemical burn.
Powder chemical burn.
Okay, so that's the answer. When it is a powdered chemical burn, when that is thrown, this trickling sign will not be there.
Yes.
Okay.
Okay, sir. Thank you, sir.
So let's sum up now, sir. Let's sum up for a minute and then we can go to the next case.
Dr. GK, please.
Yeah. So now we had one case about facial burns, chemical burns especially. So what you need to do as postgraduates, you need to know about what are the sequelae that occur. That is very important because Dr. Nellaiper was asking about what are the sequelae that occur. So before you understand the sequelae, you must understand how the process had occurred, why microstomia developed. Actually, Dr. Bhattacharya sir was asking about split the word into micro and stomia. So it's small mouth, that is the stoma. So that will give you an interesting point about why it has occurred. So that you need to know. And then only then you can go on to the treatment aspect. The treatment aspect, of course, we're talking about commissure release. And you are also mentioned about the difficulty in intubation. So when there is a difficulty in intubation, we have to understand what are all the alternative methods that you can do as surgeons. It is an anesthetist work, but the surgeon will be involved in that work also. So it is not completely an anesthetist job. You are also a part of that team. So you should understand that also. So these are the certain points that I wanted to stress here. Whenever you get facial burns, these are the points. I think Dr. Umar and Dr. Nellaiper and of course the Bhattacharya sir have clearly discussed all the points regarding the facial burns. Please remember all these points, whoever is watching, and remember all these points whenever you get a case with facial burns, you have to answer all these questions. Thank you.
Thank you, sir.
Thank you.
Now I'd like to request any remarks from the OC or overseas faculty or any judges' remarks. If we are not having any remarks, we just questions. Can we move to the third spot?
I would like to make one in continuity with Dr. GK, is that it's not always necessary that the anesthetist will struggle for intubation. Many a times the anesthetist may ask for help, which he was indicating, whether it's a PVC neck or commissure, they need your help of 1 or 2 minutes. And you help them to, you do some maneuver, and then their intubation becomes easier. The maneuver is simple, that they make the patient deep and you incise the scar to their expectation and to their satisfaction, and then they intubate. You release this scar and then you proceed with rest of it. This is a very practical thing which has happened, which usually happens, and many of the people do not appreciate this, and sometimes they cancel the case because intubation cannot be done. But the simple procedure is this, that the surgeon helps the anesthetist.
You must know how to do it.
Yeah.
Can we move to the third spotter, sir?
Yes.
Now I'd like to request Mohapatra sir and Smita ma'am to please lead the questions for team 1.
Well,
Hi, good evening, everybody.
Yeah.
Good evening, ma'am.
Sorry, I'm late. I was in a meeting. I'm very sorry. Yeah, we can continue.
Smita madam, you can ask.
Okay, identify this.
This is a mitten applied after the topical antimicrobial application.
What is the case?
Just
describe the case, na? Like sir told. Tell some little bit, whatever you can see in the image.
You can see a mitten over the hand.
Okay.
Which might be a burn hand over which the topical antimicrobial is applied, and then the mitten is covered over the hand.
Why do you think this has been applied?
The active physiotherapy, as well as to protect it from the external environment.
So this is a case of hand burns. What is the depth of burn do you expect in this kind of, if you see this kind of dressing? What is the depth of burn expected?
Superficial dermal one, in which we can go conservatively.
Partial thickness burn, sir.
Now, how do you classify burns according to depth?
Epidermal, superficial dermal, deep dermal, and full thickness burns.
Okay. So it is definitely not superficial. Anything more than superficial burn.
Deep.
Okay.
So what are the advantage of this kind of a glove dressing over your regular dressing?
It provides active movements of the hand, so physiotherapy is appreciated, and also the edema would reduce as compared to the conventional dressings.
So how many once and how many days do you change this? Have you used it in your center?
Yes, ma'am.
Yes.
So once in how many days do you use it? And what is there? What are the layers in this glove, or what is there inside?
There is antimicrobial topical application, ma'am, and
Right.
we change every 12 to 24 hours.
Okay. So you mean every other day? You know what the cost of these gloves are?
We have
No. Okay.
conventional.
So suppose you don't have this kind of gloves available in your hospital, how do you do the dressing?
We are using conventional gloves that we are wearing during the surgeries.
Conventional gloves.
Over the antimicrobials.
You mean to say conventional latex gloves?
Latex.
So how it is effective? Okay, what are the other methods to dress the hand?
Sir, we can use over the Jalonate or chlorhexidine impregnated gauze.
Okay.
Along with splint.
What precautions do you need to take when you dress the hand burns?
It should not be too tight so that it can compromise the vascularity as well as
if splintage has been given, so the splintage should be in a proper functional position of immobilization to reduce the maximum edema in the hand if splintage is given. And we should promote physiotherapy. If splintage is given, daytime physiotherapy we can advise.
So
And
with the
nighttime
glove, how will you use this physiotherapy? I mean, splint.
No, not with the splint, ma'am.
No, that means when you use the gloves, you don't use a splint at all. And you expect the patient to be like continuously doing physiotherapy through the day and night. Or is there any role of a night splintage even with the gloves?
There has to be, ma'am, because
we should use night splintage.
We have to give live splintage whether we use glove or not, ma'am.
All right. So identify the other structure on the slide. If you don't know, we'll pass it to the next team.
MB can answer.
Sir, this BioBrain gloves, sir. This acts as a temporary cover for partial thickness bonds and acts as a protective covering for even for the mesh skin grafts, sir.
And it can be used after excision of the buns also, sir, as a protective film. So it has a nylon fibers.
Nylon and collagens and silicone, sir.
Two-layer, bilayer.
Bilayered product.
What color is it looking like? BioBrain is in that color? Are you talking about the glove or are you talking about the other one?
We are talking about the black one, ma'am.
Yeah, which dressing is black in color, yeah? The other team?
What are
Ma'am,
the
sorry,
antimicrobial? Yeah, tell.
Sir, black one is Acticoat, sir, and white one is BioBrain. Confused.
Yeah, okay. Black one is the Acticoat dressing.
Acticoat dressing, ma'am. White one is BioBrain.
Okay, can you tell me something about the Acticoat? What are the layers in the Acticoat dressing?
Acticoat has a nylon mesh, ma'am, in that it will be having silver. It is embroidered with silver. Silver will release and it has antimicrobial activity. So
it directly acts on the microbes and it will prevent the DNA applications of the microbes, ma'am. So this proper dressing, which has a hydrofiber, which absorb the moisture, maintain the moisturous environment, and it absorb the exudates.
And it can be kept up to 1 week, ma'am.
Yeah, it contains what? Nanocrystalline silver.
Yes, ma'am. Yes.
What are the common causes of this kind of hand injuries? Burn injuries of hand?
It can be due to firearm flame burns, due to the firecrackers, or in case of electric burn as well as in scald burn.
In bonfire also.
In thermal burn also, in flame burn in bonfire.
Right. So if a patient comes with firecracker burn of the hand, how will you proceed in emergency? Only the firecracker burn of the hand. How will you do the assessment and proceed?
First, we will check the airway breathing circulation and then to the hand. Then on inspection, I will check for the local tissue edema or the vascularity, sensation, and movement of the hand.
Sir, Tim can add something.
Sir, also I would like to inquire about the mode of injury, whether it was firecracker, it was where the patient was nearby, the blast took in the patient's hand, or it was just due to the burns which he got due to flames.
We will also shout an X-ray for the bony deformity.
Any bony injuries are there or not, and look for edema of the hand.
What about pain management?
We'll
When
start.
will you do pain management?
So during if the wound is dressed, we during the examination only we have to give the sir.
Sir, sorry to interrupt, sir. The allotted time is over, sir.
Yeah, okay.
You can just answer the questions and give answer for the questions which were not answered by the PGs.
Regarding pain management, I was just asking, so you have to think about other team. Would you like to answer this one? How do you manage the pain in case of particular cracker burst and hand injuries?
By analgesics.
No, you have to give a wrist
patient
block.
Nerve block we can give, sir.
Yeah.
Blocks.
Early in the evaluation, when you make a preliminary evaluation, give a wrist block. Then you send for X-rays and all other further things. Any point from the moderator, sir? GK sir, anything you want to add?
Yeah. Now, the discussion was quite interesting because I think you talked about all the things about hand burns management. And the dressings also, madam also was stressing on the different types of dressings. The postgraduates should know about every single dressing. They answered correctly about the Acticoat dressing. All the other dressings also they need to know about and answer in the exam. The other thing was the depth. How will you assess the burn, Dr. Devi Prasad was asking. When you see the patient with a cracker burst injury, and how will you proceed? There, it should be stepwise. When you talk about how will you manage the patient in the emergency ER, patient with a cracker burst. So the first thing is you need to evaluate the wound. How will you evaluate the depth of the wound? You are not very clear in that. You need to be clear when you're talking about the depth of the wound. How will you assess the depth of the wound in the palm? It is not just an ordinary, the superficial second degree burn, you will have a blister and all that. Palm is different because it's got thicker skin, isn't it? Thicker dermis. So how will you assess the depth in the palm?
Palmar edema will be much more in the deep dermal burns.
In all burns, the palmar edema will be there, yes.
Sir.
And then?
The position of the hand.
Yes.
Intrinsic. Hand may go into the position of intrinsic minus position, sir.
Yes, correct. And then when you talk about how will you manage, you're going to talk about two things. One is what are you going to apply on the wound? And second is how are you going to do the dressing? There are two different things, isn't it? First, you need to apply something on it. What will you apply generally in the ER?
Sir, we wash the hand with the saline and then we cover with the paraffin soaked gauze or chlorhexidine soaked gauze.
Yeah. And then here,
and splintage in the
splintage of the hand.
Yeah, dressing. No, first splintage. Before splintage, you must always talk about the bulky dressings. Bulky dressings are very important. And when Dr. Devi Prasad is asking about the dressing, you should talk about gauze between the fingers. That is very
in between the web spaces.
You should mention is the gauze between the fingers and bulky dressing. You kept saying splint. What splint would you apply? In what position?
in
dorsal or volar?
Sir, we like to give the position of immobilization, so we'll apply the volar splint, sir.
Volar splint in what position of the joints? Tell me the joints, what position they will be.
Sir, wrist in 15 to 15 degrees of extension, MCP joints at 70 to 80 degrees of flexion, and IP joints straight, and thumb in abducted positions.
Yes. Now, applying a splint in the emergency situation, you should know what are all things going to happen. How long will the splint last? You're going to apply what material are you applying as a splint?
POP will not last long, sir.
Yes. Yes.
So we can go for either fiberglass or thermoplastic. Or thermoplastic splint, sir.
Thermoplastic or fiberglass, but you should be very worried about the edema that's going to develop.
Yes, sir.
So that also you should know. I think you have answered quite okay about the hand burns. If Dr. Devi Prasad and Dr. Madam are okay with it, any other comments from our seniors? Bhattacharya, sir?
Yes, but I would like to say that these, for example, these gloves may look nice, but as Dr. Karthikeyan was insisting that you have to put gauze pieces in between the fingers in the web space, and these gloves may not allow all those. Again, this doesn't allow you to see the wounds very frequently, because then you have to change the gloves every time. Sometimes in the initial phase, you might have to change twice a day dressing, even if it is a bulky dressing, because it gets soaked. And the third thing which I wanted to mention is that regarding the pain, the local pain, if you don't know how to give wrist block, and if you don't have the facilities immediately, then mix whatever cream you are using. Usually we use silver sulfadiazine cream, and mix lignocaine jelly with silver sulfadiazine.
Topical.
So that relieves the pain quite a bit in any depth of burn, especially in superficial burn, definitely. So this is a practical tip that mix lignocaine with silver sulfadiazine.
As a matter of fact, hand burn is something, if I tell my I used to tell my postgraduate, if you are able to manage a hand burn correctly, and the wounds heal beautifully and function is retained, you can be given a pass for plastic surgery. Because it follows every single principle of plastic surgery is followed, has to be followed correctly.
And ultimately, it is the function of the hand, apart from wound healing. Wound may heal in different category of burn in a different way. But ultimately, we have to keep in mind the function of the hand.
Sir, if questions are over, can I move to the second team and we'll start?
Yes, I think so. Yeah.
Venkatratnam, sir, you want to comment anything about it finally? I don't think.
One of the fundamental points in limb injuries or burns, whatever it is, most fundamental thing. Most fundamental thing, I think which you have missed. After your dressing is over, what will you do? One of the fundamentals. Limb
elevation.
Wait, pardon?
Limb elevation.
Exactly. That none of you told. How many types of elevation you know? Okay, I'll give you a clue. In the mobile patient and in the bedridden patient.
In the mobile patient, we will give a sling.
Yes.
So in bedridden patient, we will apply a pillow underneath the arm and give a splint edge, give a sling that hang the cast to the stand.
Say it again.
Sir, in a bedridden patient, we'll like to flex the elbow and we'll place a pillow under the arm, and then we'll give a sling for hanging of the hand, so it will give a limb elevation to be there.
From where it will hang?
Sir, from proximal to the elbow. The
Hang
sling will be given. No.
But what's the other end of the sling? On your neck or onto the frame or anything like
that? Sir, either we can use IV stand, or we can, in case of mobilizing patient, we use we can give over the neck. The sling can be tied over the neck.
Yes. Another thing which was not everywhere described is your stock in it. A stock in it, you can make it a full, say for example, 1.5 meters. Make a window at the hand where you want to attend, and the rest of it you can tie to the beam or to the IV stand. That is another simpler thing. With or without your splint, you can use this. Okay, over. Thank you.
Thank you, sir. Now we will move to the team 2, sir. Usmania, their first spotter. Team 2, Usmania, your first spotter. Bhattacharya, sir, please give a brief history of this case. Request.
This is a scald burn which has happened, and it's localized to the temporal region, the ear and the cervical area, and over the neck and upper chest. And this is 2 days old.
Thank you, sir. Now I would like to request Umar sir and Niliapur sir to lead questions.
So, what degree of scald burns present here?
Team 2, Osmania.
Sir,
Team
it's
2.
type 2 degree of thermal burn, sir.
Okay.
Involving right ear and post-auricular region, cervical and upper part of neck, sir. And superficial burns over the neck, sir.
Okay.
Sir, and the patient is having a scald burns over the ear, sir. So here we are more bothered about the ear, sir. So we should not put any pressure over the ear, as and blips we have to rupture over the ear.
And
we have to do contour dressing.
Okay, this patient that comes to you. Okay.
Contour dressing we have to do, sir, for
contour
ear.
Dressing. Why?
Contour dressing
with minimal pressure.
With minimal pressure.
How will you do the contour testing? How will you do the contour?
Sir, initially thorough wash has to be given, sir. All the foreign body debris has to be cleared up. Then mephinate ointment, if available, has to be applied. Then over it, the paraffin gauze has to be kept, sir. And over that gauze piece and this minimal pad has to keep, and over it the minimal plaster or roller has to keep, sir, and keep the head elevated and the pressure should not be over the right side, sir. Either donut has to be kept, and with the donut patient has to keep the head, sir.
Okay. So why should ear burns as significant dressing? Why does it require? Why does it require such thing?
Cartilage, sir, because it is ear cartilage. Once cartilage doesn't have any fat.
What is the blood supply of this ear cartilage? How it
from the surrounding structure? Cartilage does not have any
ear cartilage.
Yes, from the surrounding structure it will get, sir. Once it got exposed, it may go into rapid infection, sir. It may go into chondritis
and
it become deadly complications. In order to prevent that, ointment has to keep, sir. Ointment, method like ointment has to keep. and
What
to-
deadly complications? Cartilage may become, the skin pore may become infected, and as you said, abscess can come. What is the deadly complications we are thinking about?
Even it may go into necrosis, sir.
Ear deformity, sir.
Okay. Ear deformity can come. What deformities?
Cup ear. And
What
loss,
can happen to the
cartilage loss can occur, sir. And
how can you prevent that?
By covering, sir, by doing dressing, and by giving contour dressing.
And we have to do we have to do proper debridement.
Proper
sir.
debridement and early grafting.
Debridement of what? What will you debride?
Debridement of the bun tissue, sir, and early grafting we have to do, sir. Early skin grafting.
Debridement, you will excise skin. You will do excision.
No, sir,
No,
not.
sir. If suppose after debridement, if we come to know if there is any loss or any necrosed tissues, then we have to go for coverage, sir.
I mean to say, what are you trying to debride? What will you debride?
Any loose tissue, sir. Loose tissue will debride, sir.
Loose tissue will debride.
Loose, burnt, necrosed tissues.
If there is disproportionate edema of the external ear, how will you proceed? It looks quite edematous, right?
Sir. Incisions.
Can you do something to preserve the cartilage?
If they are not answering, can you ask the next team, sir?
Yes, sir. Yes, sir. Team, another team.
We can give a bivalve incision and split the ear, and then release the edematous fluid, and then again suture.
Where will you give the incision or make the incision?
Incision is given in the post-auricular region, sir, and not in.
Team KGMU, where will you give the incision classically? KGMU.
Over the edge of the ears.
Over the edges of the ear.
In the helix, so that we can split in two part and release the edematous fluid.
Now you were telling, Usmania, you were telling that there can be the loss of cartilage, right?
Yes, sir.
It is one of the complications. What could be the causes of the cartilage loss or the, what are the pathogens? How will we lose it?
It's because of infections, sir. Infections and ischemic changes that may go into.
One is the infection. Infection occurs, then you can lose a cartilage, right?
Yes, sir.
Any other mechanism? How does cartilage survive?
Because decreased blood supply, sir, full thickness loss of the skin over the cartilage, it can go for necrosis.
It can go for necrosis. These are the mechanisms for who can lose the cartilage, right?
Yes, sir.
Now, how will you manage this patient? Other areas, if you see this patient as a whole, how will you manage him?
Sir, already patient. Sir, other areas were having only superficial. So if patient has presented early to me, I will apply collagen, sir. Collagen coverage can be done.
Collagen or? Where will you apply collagen?
If patient presented early, sir, we can apply over the chest, nose, and neck region also we can apply, sir. Whole area we can apply.
What is the indication of applying collagen?
Sir, for up to partial degree burns, we can apply collagen, sir. For facial burns, we can apply collagen, sir. And even
Patient has to present early, sir.
Within 12 hours, they have
within
to
12
present.
hours they have to present, sir.
So that the wound will be clean without any organisms. So it's ideal time to keep collagen.
But this patient has presented you after on second day in the introduction. Sir told like that.
This case, I will go for conservative management of the burn area, sir. Daily application of the silver sulfadiazine local application, I will manage it, sir. For a year, we will do contour dressing with minimal pressure.
Contour dressing with what? Will you use some ointment, some cream
Mephenide,
on
sir,
ear also? Huh?
Mephenide is preferred for the ear, sir, because
why?
Because it has a extensive gram-negative coverage, sir.
Team KGMU?
So because of the deeper penetration, the mephenide, and over the face, we can apply a topical antimicrobial like
just one
fusidic acid.
question. You have replied that. Now we'll again go to Usmania. It was just if we passed on to it. So, Team Usmania, you are applying mephenide over it. Are you getting mephenide in your unit or not? Is mephenide available to you in your unit, in your hospital?
No.
Yes or no?
No, sir.
No, sir.
No, sir. KGMU, are you applying mephenide?
No, sir.
Is it available in India, Usmania? Good. Okay, Dr. Nilapar, sir.
Okay. This patient, then how will you follow it up? You are doing this dressing. On day one, debride the wound, apply collagen, and this soft dressing to this ear lobe. How will you follow it up? What will you do on the subsequent days?
We will monitor the ear, sir. Ear, mainly
Okay.
ear in case whether patient is developing any edema of the ear or not, and daily contour dressing should be done for the ear, sir. Old dressing should be removed, and again dressing should be done daily. In this case, if edema develops, we have to give incision over the helical region to relieve the edema. This case, any loose necrotic tissue is there, we have to debride it. Early debridement, as it is here.
Sir, given time is over, can
Yeah.
answer the questions which were not answered by the speakers.
Yes, GK sir, Bhattacharya sir, anything you want to add? Actually, mephenide is not available. As per my knowledge goes, it is not available here in India. I don't know now.
Plastiquest, sir, do you have any comments?
And when you have to give the incision in the air, you have to go along the helical margin. So you try to elevate on like a leaf, two leaves, so that the edema goes down, so you can preserve the cartilage.
See, you need to understand.
Sir can moderate.
As far as the burns on the face are concerned, two very important structures. One is the eye, second is the ear. In the ear, you can get chondritis, perichondritis. In the eye, you can get, what do you get in the eye? Ophthalmia, periophthalmitis, which will result in what condition? In a condition called phthisis bulbi, where the entire globe becomes soft, and it happens overnight. So you're very worried about that. As far as the ear is concerned, as Dr. Umar was saying, you bivalve the incision. You make it over the rim, the ear rim, open it up, open like the two leaves of a book, scoop out all the dead cartilage from inside. You will have a little cartilage still remaining. Leave that there. Just scoop out all the, it will come out like cheese. Cheesy will come out. That is the dead cartilage. Once you have done that, put in a non-adherent dressing inside, put the leaves of the book back, then put a dressing in the post-auricular region, put a padding in the post-auricular region, pin the ear back gently, and put a contour dressing. Now, the idea you need to understand is, the idea why this bivalving is done is you want to preserve that skin. If you do not do this procedure, as the cartilage keeps necrosing, the skin also goes into contracture and it becomes very small. Now, there was one question about why the cartilage is involved. They were talking about infection. Yes, infection, yes, but more importantly, ischemia to the cartilage. Cartilage does not have its own blood supply. It depends on the soft tissues. And I think one of the postgraduates mentioned that in a full thickness burn, the cartilage gets involved. Not at all. Even in a superficial burn, because of the edema that comes into the skin, now there is not much soft tissue there. It is just cartilage, perichondrium, and the skin. So when it's so soft that if the edema comes in, the blood supply to the cartilage is cut off. That is what causes the ischemia of the cartilage. So here, by bivalving the ear, you're preventing the skin from going. So if by this procedure, what is dead is already gone. What is remaining, you have preserved. But more importantly, you have preserved the skin envelope. It's called the skin envelope. This skin envelope, if it is preserved, you can always go in later after all the wounds heal to do a ear reconstruction, because you know how difficult it is to get skin and cartilage over the cartilage that you're going to make for microtia. So when you preserve the skin, it is very important that you do this bivalving procedure, as Dr. Umar was mentioning. And the other thing was about the eye. The eye also is very important. And of course, it is not coming in this discussion, but that also you should know about how to protect the eye. The eye and the ear must be protected. Today, I think you have learned all about how the ear needs to be protected. And you also spoke well about the contour dressings that you need to do. Yeah.
I think that, I think it's a very crucial decision when to put the incision on the helical rim. And it is not that today you see and tomorrow again you see. This area in the acute burn like this has to be revisited repeatedly, at least thrice a day, in the morning, afternoon, in the evening maybe. And you feel the skin, that how much it is tense. If you are able to compress it, still you can wait that decompression incision. You wait, but this judgment is so important, because once you make the incision, you have opened it up, the skin little bit retracts, and the cartilage becomes more exposed. Initially, the cartilage doesn't get necrosed. It may get exposed. Later on, it may. But therefore, this incision of release over the helical rim is extremely crucial when to do, and your clinical sense that, well, this skin is, this edema will subside, this skin is viable, and this may not expose there may not be necrosis immediately, because immediately necrosis doesn't happen. It takes time. But that crucial time when to make the incision is extremely important. Because once you have made it, you have committed, and then sometimes that itself may expose the underlying cartilage and cause problem. So this, what I wanted to emphasize is crucial decision of making the incision on the helical rim.
Thank you, sir. If there are no questions from any other faculty and other senior faculty, can I move to the second spotter, sir? Any queries? Okay, sir. I will move to the second spotter. Now I'd like to request Devi sir and Smita ma'am to lead the questions. And Bhattacharya sir, please kindly give some brief
this was following electrical injury, and it came very late, almost 1 month post burn, and you can see the granulation tissue, etc. And the question was of the condition of the exposed bone, how to manage.
Sir, it's a picture showing a defect over the left parento occipital region, sir, with exposed bone with periosteum loss is there, sir. Is surrounded by a granulation tissue. Could be of late presentation, sir, of electrical burn.
Sir, the bone doesn't have any periosteum, sir. So it did not have any blood supply, sir. So, and
do you think the bone is viable?
Yes, sir.
How will you know whether a bone is viable or non-viable?
Viable bone will be ivory white in color, sir. Dead bone will be chalky white in color.
Then what other features? Can you tell other features which can help in distinguishing?
Viable bone will be having periosteum will be there over the bone, sir. Dead bone will not have periosteum over it. And
any other? You should take to OT, operation theater. Is there a way to know whether the bone is viable or not?
Live bone is shiny and lustrous, sir.
That you told already. Any other thing? Okay. So now you have a patient with this kind of defect on the scalp. So how will you proceed for management?
Because as periosteum is absent in this case, sir, so skin grafting is not possible. So I'll go for local transposition flap, sir.
So is there any other way you can get away with a skin graft on this wound?
We can keep drill holes so that outer table from dipole the granulation tissue may come outside, so that we can graft it later, ma'am.
So what will be the disadvantage there?
Hair loss will be.
It will be delayed procedure, ma'am. So we have to wait till the granulation tissue develops.
Yeah. The chance of
And
infection.
then alopecia also in that area. And during the waiting time, like you said, infection also. But is that a suggested methodology here? What conditions would you want to do that?
Usually done for
the second thing?
If more for smaller regions, if more calvaria is exposed, then we can go for drilling.
No, you didn't get the question. And we
Yes,
will
sir.
answer it later. Okay, like Dr. Davis said, what is your plan of action for this case now?
How will you proceed for management?
sir, local transposition flap. I won't.
Okay, will you directly just jump and do a transposition?
I will do the debridement, sir. Whatever the unnecessary granulation is there that we have to remove, then until the fresh bleed comes, we have to do the debridement, sir. Then based on the deferred size, we have to proceed, sir, with the rotation or a transposition flap, sir.
Other team, can you suggest something more?
CT scan of the head I will do, sir, to know about the bone wind. CT scan of the head with bony window, sir, to see the bone, any osteomyelitic changes are started or not in the bone, and any intracranial injury, previous injury.
Okay. So suppose you find that there is a full thickness involvement of the bone, both outer and inner table, then what would be the plan?
Then I will go for a cranioplasty, sir, with titanium mesh followed by flap cover, or coastal rib cartilage graft with flap cover, local flap cover.
What are the different methods for plan? So we are talking, suppose we have a full thickness defect. So what are the other methods for restoring the bone?
One is we can bone graft.
If it is a small defect, what are the methods?
If it is
even
small
from
defect, we can do gallial scoring and primary closure, sir. Calv defect.
No, we are talking about the bone defect. I'm talking about a bone.
if it's a small defect, then we can
Iliac
go
crest,
for
we can take
iliac
iliac
crest
crest.
or rib graft. We can take, sir.
If it is larger defect, then
Split rib graft, split rib graft, sir.
other team would like to answer this. What is the option for you if you have a full thickness defect of the calvarial bone?
KGMU.
Apart from autologous, we can go for acrylic implant or.
In autologous, what are the options for you?
Sir, split rib grafting, iliac crest.
Madam, you can continue.
Mita ma'am.
Yeah. Okay. This patient is on the table. You've debrided. You've scooped out the granulation tissue, and you feel the outer table is okay. That means it's not osteomyelitic. So, how would you plan the procedure? What procedure will be your choice for?
After debridement, I will do a local flap cover, ma'am, so that the bone can survive based on the flap blood supply, ma'am. So
before that, won't you triangulate the defect, or you want to before the planning? Won't you? You should go step by step, no?
Yes, ma'am.
So
After
now the
debridement,
granulation tissue is scooped. So what kind of a defect is this?
if the granulation tissue, unhealthy granulation tissue is debrided, ma'am, it looks like a triangular defect, ma'am.
Yeah. So then now you tell me triangular defect on the scalp in that area. What will be your choice of the flap?
I'll go for a right superficial temporal artery based rotation flap, ma'am.
Right side superficial temporal artery based rotation flap. So what is your marking of rotation flap now on this patient?
From occipital incision extends from occipital region, ma'am. Ma'am, I'll go for anteriorly based transposition.
Ma'am, we can go with the anterior based transposition flap, ma'am.
Not she, you will go.
Yes.
What do you mean by anterior based transposition flap? Yeah.
Ma'am, is based on blood supply from the
frontal and superior.
No, what kind of a triangle will be when you triangulate this?
Isosceles,
what kind of triangle will
it becomes an isosceles triangle, ma'am, because the two will be equal down one.
Yeah. So if you want to plan a transposition flap, what kind of triangle should be, and where will you plan accordingly? What are you doing, a transposition or rotation now?
It is an isosceles triangle, ma'am. So we have to plan for a rotational flap, ma'am.
Okay, so you tell me what is the marking for a rotation flap? Okay, maybe not on this patient. Otherwise, how do you mark a rotation flap?
Ma'am, for rotation flap, if inverted triangle is taken, first, ma'am, inverted triangle is taken. So
okay.
Then
see.
See, and the arc will be taken based on the base of the triangle, ma'am. So it will be more, it comes like.
What will be the dimensions of the circle which will make? You're making a circle, no, for a rotation flap to happen. So what will be the dimensions?
6 times the AB level, sir.
There is no A, there is no B. Try to describe the anatomical terms which you are seeing.
The radius will be 1.5 times triangle border.
Okay.
Radius of the triangle is taken as
Okay.
1.5.
When you raise the flap, what is the layer at which you will raise the flap?
Subgaleal layer, sir. I'll raise the flap in scalp and subgaleal layer.
And what are the precautions you will take while raising the flap?
Before raising the flap, we have to infiltrate the scalp, sir. It is highly vascular, so we have to infiltrate it with adrenaline saline before into the subgaleal plane. Then, while raising the flap, we should not injure the periosteum, sir, because if damages, graft uptake will not be there. After raising
you're planning a rotation flap. So no question.
Yes, sir. Rotation.
Okay.
So where will the graft be? There is no graft, no?
Yes, ma'am. After raising the flap, if upper reach is not coming, we can go for a Gallial scoring, ma'am.
If the reach is not coming, what are the other options to do other than Gallial scoring?
We can go for back.
What did I
Burrows
decide?
triangle we can do for Burrows triangles, a back cut and Burrows triangle we can make it.
No, what is the disadvantage of Gallial scoring? What could happen? Have you done it?
Vascularity of the flap may decrease, sir, because we may injure the main vessels, pedicle vessels.
You may injure the
vessels.
What? A transversion flap on any other part of the body is take like back or something and scalp. What is the difference? Anything rotation or transposition when you raise a flap on the scalp or on the back, what is the difference?
Because it's a tougher, the elasticity is less in the scalp and back, sir.
Yeah. And then?
What is the disadvantage of a transversion flap on the scalp?
Because we have to keep grafted the donor side, ma'am. So alopecia will be developed at the donor side, donor area.
So what can you do for that later on?
Later on, we can go for a tissue expander placement, and we can go for delayed procedure, ma'am, for tissue expander, and we can.
Okay.
Ma'am, sorry to interrupt. Allotted time is over, sir.
Yeah.
If you want to answer any questions which were not answered by these teams, you can answer, sir. Otherwise, we'll move to the moderator comments.
So regarding that, on the back and scalp, because of the presence of Gallia, it shrinks very fast. So you have to complete your procedure, whatever transposition or rotation, quite fast. Otherwise, you'll not be able to approximate the defect. And before attempting Gallial scoring, you just try to release from the other areas. Release the scalp from the other areas and try to bring them together. Gallial scoring is the last option, and generally it's not very recommended because of vascular issues. Anything, madam, you want to add, or JK sir can take over?
Yeah, JK sir can take over.
Yeah, I don't think there's much to add because the panelists have done a good job about questioning the postgraduates. But I had only one question. Why did the postgraduates keep jumping from rotation flap to transposition flap again to rotation flap? You were not sure of yourself, isn't it? Why was it? And the next thing is, when madam was asking what triangle is it, you need to say it's an isosceles triangle with the apex pointing anteriorly. So that will give an idea of what is going to be the orientation of the defect and what is the possible flaps that could be taken. So these are things, I mean, local flaps, rotation flap, transposition flap, scalp, you have to answer. You have to answer without any doubts in your mind at all. Otherwise, I don't think there's anything from my side.
One more point, yes, I want to add regarding, I was asking the team about the bone graft. So whenever you are around the scalp, we prefer a calvareal bone graft. Why would you go to a different place? You can harvest a calvareal bone, outer table or inner table can be taken and used to resurface the defect. That is, generally we choose tissues which are nearby to the defect. My first choice would have been a calvareal bone graft to resurface any bone defect. Later on, rib graft or other whatever other options the team members told. That's all.
I would like to add little practical tips. Number one is when you debride this wound, then you should incise all around nicely, not only the granulation tissue and bone, incise about 0.5 centimeter of the skin also, because ultimately you have to suture the flap to the margin. And if you don't incise that, then that area is not suitable for flap insetting, number one. Number two is that before committing, of course, you will do a CT and then decide the whether both the tables are involved or not. Otherwise, many a times only the outer table is involved. And then if you insinuate an instrument, and a bone elevator or something like that, and you just give a upthrust, the outer table comes out and the inner table remains intact. Then the management is totally different. The third thing is regarding flaps. See, as Dr. Devi Prasad was mentioning, that the laxity of the skull is not as much as in, say, in other areas. And therefore, even if you do a rotation flap, you might have problem of closure, primary closure of the whole area, the flap as well as the donor side. And many times it is not it is not necessary that you have to use one flap in every case. You can always use two flaps. So even two rotation flaps. So it ultimately suture line comes like an S. So there you can have advantage of the rotation flap as well as easy closure of the donor side, because this is very practical that you use is anywhere in the body. You divide. If you don't have adequate tissue, you can plan always two flaps, sometimes even the three flaps. And the last point is that always keep in mind the anterior hairline, because even if you have to graft in some area, it should not hinder with the anterior hairline, because the hair grows and covers that graft area. So these are the practical tips which I wanted to give.
Can I add one more thing? It's
Yes.
what you call as a history, a little bit of history. Supposing you had a bigger defect on the scalp, how would you replace it with a flap? How would you reconstruct with a flap? A very large defect, almost the entire scalp is open like this with the bone exposed.
Mental flap.
Sir, we can use 3 pedicle flap. We can raise from the occipital region. If it is in the vertex region, we can.
What is that flap called?
Okay.
Sorry, not remembering the name.
You can tell either the proper name or you can tell the colloquial name that we give to it.
Banana. Multiple finger like.
You feel it like what?
Banana flap.
Banana peel or the artichosia flap.
Artichosia.
That is when you have a little bit of skin around. Supposing the entire scalp, you've got a defect. I can see Dr. Bhattacharya sir smiling. This is something that you will find only in history books. But you can get a defect like that. And when you're not able to do microsurgery, you should know all this. Please remember, microsurgery is not the answer to everything. Microsurgery definitely can answer a lot of questions, but there are some situations where you cannot do, or microsurgery has been done and it has failed. What do you do then? A large defect on the scalp. Can you move a flap from one part of the body to another? What are the different ways in which a flap can move? Yes, you should tell me this.
Advanced, pedicle or free?
Sir, it can advance. We can advance or.
How does the flap move from one place to another?
Type of movement.
Types of movement, yes, exactly. Exact words.
Transposition or advancement.
When you have a defect, no, transposition flap is the flap moves to the defect. I'm talking about how the flap will move from one place to another. For instance, you are having a defect on the hand. You're doing a groin flap. So your groin flap tissue from the groin has moved to the hand. How did it move there?
It is pedicle.
Tube pedicles.
Tube pedicle, yes. How do tube pedicle flaps move? What are the different ways in which they move?
In a dance?
No, I think they should know this. This is very important. Okay, shall we give them the answer or should they find out, sir?
Yes, sir, we can give them.
I will give more clues, sir. Does it move my rock and roll or salsa, or does it waltz, or what kind of movement is it?
Sir, waltzing.
Not one.
Yes, waltzing is one. Yes. Then
one of them, yes.
Something which moves on the leaves.
one, sir.
Somersault.
Okay, somersault. Okay, that is one. Yes.
Okay.
Then
Frog.
sir said no, something moves on the leaf.
Caterpillar.
Caterpillar, yes. And these are three movements which are very slow. Which is the fast movement? There is one movement that is very fast. These take a lot of time.
Wrist as a carrier. Surgeon moving its.
Surgeon moving. Surgeon moves away from the theatre. Huh?
No, sir. Wrist as a carrier.
Carrier, yes. Wrist as a carrier. That is how the flaps move. Okay. So now, please remember, these are important things. You will face such situations in your practice also. Not only in the exam, also in your practice, where you may have to move a flap from one place to another. So using the wrist carrier is the commonest because the hand can move to many places. So that is why you use the wrist. And one of the people have commented in the chat box also about the extracorporeal flap. Okay. So why this question was asked was for the scalp, you do what is known as a kangaroo flap. Okay. You take the skin from the abdomen, hitch it on to the forearm, the entire forearm, entire length of the forearm. Okay. Take the large superiorly based abdominal flap. I mean, I cannot go into the details now, but it's a very interesting procedure by which there is never any raw area at any point of time. And then it moves on to the head like that. So there's an extracorporeal flap movement. Okay. It moves from the abdominal skin, the entire abdominal skin can be moved to the scalp. So what you need to know is what are the different types of flap movement and what is extracorporeal flap. Knowing about microsurgery is good, but knowing about these is also very important.
Okay, sir. If there are no questions from your faculty.
Yeah. Next one, please.
Sure, sir. Final spotter, sir. Team 2. I would like to request Neliappa sir and Umar sir to read the questions.
Team Usmania?
Yes, sir.
What can you see in these pictures?
Sir, first one is Humvee's knife with rectangular one, sir. And the second one is
Rivedian pinch.
What is the first one? What is first one? What is first one?
Humvee's knife, sir, with
the rectangular rods.
Rectangular rods. Why are these rods there?
Make the surface even, sir.
They will have they will stretch the skin, sir, while taking the graft for stretching of the skin.
Okay. And what is the next one?
Next one is Rivedian's pinch graft blade, sir. So the above one, the blade will hold, lift the skin, and with scissors he used to cut the small grafts. So Rivedian's pinch graft scissors, the second one. And this one is soaps. This is soaps also.
Bread weight.
Bread weight.
It's a bread weight skin.
Boardman. And the left side down one is Boardman skin grafting knife, sir. And the right side one is the dermatome, sir.
What are all these collection of instruments? What
These
are
are the
these for?
evolution of skin grafting in the plastic surgery, sir. So first Riverdin
Actually,
has
this slide depicts about the evolution of
skin grafting in
instruments or whatever you called. Can you tell me something about the evolution? How did it evolve?
so first
How
Riverdin
was
has
the
done
first?
first was done by Riverdin, sir. He used to take a small pinch grafts, sir, small grafts, and he used to allow the donor sites to heal primarily.
With what he
And,
will take?
Not that. Evolution of the grafting instruments, or what you call today the grafting handle. How did it evaluate? We have nothing to do with the Riverdins, this pinch graft instrument. Leave it.
Okay, sir.
What are you using in your unit this time?
We are using Watson's modification of Humvee's knife, sir.
Watson's modification Humvee's knife. So how did we reach there? What was
first one was
modifications which resulted in that?
First one was yes, sir. First one was started by Humvee, sir. So he was not using a disposable blade. He was using the blade which was fixed to the graft handle. So we need to sharpen it frequently, first thing. Then while taking the graft, it used to roll around the guard. He has placed a guard at the beginning of the blade.
Can you add another team?
In Watson's modification of Humvee's knife, the guard is.
That is the how does it evolve?
Sir, initially there was.
Right that first there was nothing like changing anything.
Sir,
It
initially
was like
there
a
was
knife.
It was
right?
knife and a handle, and
what was that called? What was that called?
Knife was irreplaceable, and we have to sharpen it every time we use it.
What was that called? Who devised that?
Catlin's knife was first used, sir.
Then?
Catlin's knife was first used, and the problem with was that the thickness of the graft was not consistent. Okay, next Theus has taken, he has introduced a Theus knife, sir, for taking the graft.
I want to know about the modifications on this knife till we reach the present knife which we are using today. You got my point?
Yes, sir.
Yes. What are the features of a knife handle we use today? What are its parts? Can you name the parts? The handle we use, you use these days?
Yes, sir. The handle, we have a handle and blade compartment, handle, and calibration screw, and we have another one on the opposite side. We have for fixation of the blades, sir, for not to take it, and guard as a roller as a guard in the front. In the initial period, when they used to take the grafts, the problem came with the guard. So when the graft used to roll over the guard.
My question was about this. Don't go to history now. That is done. And what are the other instruments you can use to take a graft? What are the other instruments you can use for harvesting any graft? Skin graft, I mean.
Silver's knife we can use, sir, for taking small grafts, sir. And dermatome we can
use in silver knife.
Sir, pardon me, sir.
What do you use in silver knife?
We use razor blades, sir. Normal razor blades, sir.
Okay. Then this is one method. You use that knife. Use this and anything else.
Dermatome we can use, sir, to take the.
What are the types of dermatome?
Dermatome, we have Pega dermatome, Reese dermatome, Brown's dermatome, and
Castrovisual dermatomes.
Castrovisual dermatomes.
What is Castrovisual?
Castrovisual dermatome we can harvest in
mucosal graft, sir.
Mucosal graft. It was invented by
mucosal grafts. Why do you use mucosal grafts?
For a corneal transplant, sir, it was used for a corneal transplant.
And American eye surgeon was the one who first.
First, please listen to the question. Don't. Why do you use mucosal graft? Castrovigio, you harvest mucosal graft. Where from you harvest the mucosal graft?
Eyelid and socket deformities.
Eyelid.
If you have to harvest a mucosal graft, what is the donor side? Where from you harvest the graft?
Lower lip, sir. Lower lip.
Lower lip. Team KGMU?
Buccal
Where from you
mucosa.
harvest the mucosal graft?
The buccal mucosa.
Buccal mucosa. And Team Usmania again?
Sir.
Why do you use this mucosal graft if you raise?
In eyelid reconstruction, sir, if we want a conjunctival, for placing the conjunctiva one.
Conjunctiva. And?
And for any socket deformities.
Socket deformity. Nilepa sir, please.
Team Asmania, this you
Sir.
see the picture in the that's electrical dermatome. You said what are the parts of this instrument? You tell me.
Handle,
Dermatome.
motor.
Okay, handle. Okay.
Handle, motor unit, and we have blade.
Okay.
And calibration screw is this calibration.
Okay, in the blade, there are given here. There are. What's the difference between among these blades?
Sir,
Why there
as
are
we
different
take
blades?
the blade, we can increase the width of the grafts, sir. That is for taking the different widths of the grafts.
So, what is the difference? What are the difference between a graft taken by a dermatome and a Humphreys knife?
So the dermatome, if we take a graft, the width will be uniform, and the thickness of the graft also will be uniform.
Okay. So, in which conditions a dermatome is more useful rather than a Humphreys knife?
For taking large grafts in a short time, sir.
That is what is the most.
Even cadaveric.
Is it for taking the large graft or what is
long
important
grafts,
condition?
long graft, long and fixed width grafts when we want.
And for cadaveric in harvesting, we can take.
Okay. So how will be the edges when comparing with a Humphreys knife and the dermatome?
In Humphreys knife, the edges will
graft.
be slightly ragged in Humphreys knife, sir, but the edges will be like clean in dermatome.
Okay. That ways, regarding the edges, and anything you would like comment about the thickness in the graft between these things, which will be very uniform in the dermatome, which may not be there.
Dermatome will give uniform, sir, uniform thickness of graft.
Dermatome will be uniform. Okay. Whereas which one may not be there. So where we the main indications for using dermatome, which condition we use dermatome? Which type
dermatome
of
we can use for
especially in burns, because we have got very less donor areas when compared to other conditions. There you should not
scalp
get any
harvesting of
wastage
graft from the
in
scalp
order
you
to,
can use.
Yeah, from the scalp, other things are that dermatome should be used. So what is that other instrument which is always present along with this dermatomes? Sister concern with this dermatome.
Battery unit. Measure, sir, measure.
Measure will be the one always. Okay. So what is that? Z, you can see one Z in the dermatome of this machine. What is it? Z indicates. Can see an Z there, no?
Which company?
Which company?
Jinga.
No.
Jinga.
No.
KGMU?
Zimmer.
Zimmer, sir. Zimmer.
Yeah,
Zimmer.
Okay. Okay, sir.
Okay. Team Usmania, how do you sterilize your Humvees? Do you know?
Humvees knife blade is sir.
Not blade. Blade is a disposable thing, na?
Yes, sir. Humvees knife, they used to do it as autoclaving, sir, in olden days. And they used to sharpen the blade before each case.
Now, today we don't autoclave it. Olden days only we autoclave.
We can
How
immerse
do
it
we
in the
sterilize our
we can
Humvees handle or Humvees knife, whatever you call it?
glutaraldehyde solution, we can immerse it, sir.
How do you sterilize?
We can insert it in a glutaraldehyde, sir.
Team, दूसरी team कौन सी है? Which is second team?
KGMU.
KGMU. KGMU. How do you sterilize your handle?
We will put in Sidex solution.
2%.
In your unit, how are you sterilizing it? In your institute, hospital?
Plus autoclave.
Autoclaving. Good. Now, Team Usmania.
Sir.
You are autoclaving it. Any precautions you take before sending it for autoclaving? You always tell your assistant.
We have to remove the blade, sir. First thing.
Yes, good.
And we have to roll it in over a mop, sir. We have to roll it in the mop and then only we have to do it autoclave. Separate.
Team KGMU.
Sir, first we'll clear any debris is there or any blood clots is there from there.
Right. Good.
Then we'll dry it and then we'll keep in a gauze and then we'll send it for autoclave.
Allotted time is over. You just answer the questions which are not answered and we'll move to the moderator comments.
Actually, you try to loosen the screws. It is very important. Practical point. Don't keep these screws tight so that there is bending. You must have seen whenever you don't take the precaution, especially when you are in the emergency. We have seen here when you are in the emergency. So quickly you send this for autoclaving without loosening all the screws and all that. So there's a chance of bending, and with the result of this bending, you harvest an uneven graft. At one end there is one thickness and the other end middle there is other thickness, right? So autoclaving is a must. You cannot put it in a glutaraldehyde, what you were telling, right? Rest, I think you answered everything.
Can I?
Yes, sir, please.
In Humvees knife, you will harvest the graft by to and fro movements with your hand energy. Which sort of energy or which sort of power this Zimmer knife, whatever it is, works?
Adhesion and
Nowhere. Adhesion is not for this.
Oscillating movement.
Oscillating movement, you're right. But which oscillates it? Which is the power supply to oscillate it? Where it comes from?
Micromotors are not from the human hand, it's from the motor.
No. Okay. To save time, I will give the answer. It is pneumatic and electric. Okay. Electric, again, two types. One is you can connect to the cord, or you can put the batteries inside. There are two types. So these are the two varieties, pneumatic as well as electrical. Okay, over. Thank you.
Yeah, you need to know all about the skin grafting handle. And when Dr. Umar was asking about the evolution of the skin grafting handle, there are certain things, and he was also asking about the parts of the thing. Now, do you know what is a D block? It is one of the important steps in the evolution, the D block. Okay. If you see your handle, when you open it like that, it opens for a short distance and then it stops, isn't it? It doesn't open out completely so that the blade falls off. It never does that. It opens for a short distance. That is one important step that came in. That is called the D block. It doesn't open out completely. It opens like that. So that gives a block. That is one evolution. The second evolution was that you have the rod. They had a roller on the rod, which is great modification. So what they felt was the rod that was stiff in the beginning used to give a lot of resistance while taking the graft. So they said, why don't we make it roll so that it'll go very easily? There will not be much resistance to taking the graft. So they added the roller. I think this picture shows the roller, that the lower left picture. So now this is the modification. What is the disadvantage of this roller? You might have used the Braithwaite handle. Have you seen that roller? It keeps rolling, that the roller. So what happens is, as you keep taking the graft will start rolling up inside that, around that roller. So that was a disadvantage. So that is when they stopped that, and that has lost popularity. So now this is how the skin grafting handles has improved. And when it comes to the dermatome, you have what is called of the drum type dermatome, then you have got the electrical dermatome. The drum type dermatome, when you just have to move it like that, it just takes a limited piece. It's like a drum. You place it on the thigh and it moves like that. That's all. That is what it does. So it takes only that much of graft. You have to keep taking it. So that is one. Next came the electric dermatome, as Dr. Venkatrathman sir was saying. It comes in two power. You can have the electrical cord connection or battery operated you can have. But the disadvantage of battery operated is that it becomes very heavy. The handle becomes very heavy because that is where the battery is. So this is how it has evolved. And when you talk about skin grafting like this, you also have to talk about larger defects. We're talking about burns. Somebody was mentioning also about cadaveric graft, how to harvest. It can be used for cadaveric graft harvest because it can take large sheets, clean sheets quickly, very quickly, instead of depending on the manual skin grafting handle. Have you heard of meek skin grafting?
Yes.
Yes, sir.
Could you just explain in a moment, just a short explanation of meek skin grafting?
Meek skin grafting is done for equal.
What is the indication? Where is it used?
When large burn area is there and small donor area is there, we have to use meek skin grafting.
Very good. So what do you use? What is the principle of meek grafting?
Uniform.
Have you seen a meek graft? Those. Have you seen them?
Sir, the grafts are
shaped in a smaller square islanded shape.
And at equal distance, so they will be placed at equal distance with adhesive material is there, sir, so that we can place it.
And it can be expanded about 9 times. That,
yes.
Pre-filled gauze.
Yeah, so that is the meek grafting. And that is also one of the methods of skin grafting, one of the techniques of skin grafting. The skin graft is harvested like how we do it for everybody else. But the process by which it is expanded is by using those small machines, in which you place the graft between on a paper. It's called specialized paper. And that paper is meshed along with the graft. So when you open out the paper, the entire graft also opens out.
Right.
Yeah, so that is the meek grafting. Okay, thank you, sir. Bhattacharya, sir.
Yes, I'd like to add 3 points. A lot of disadvantage has been talked about the Humvee's knife. The margins are ragged and sometimes may not be uniform. But let me tell you that if your assistants have given good position, a tense flat position, then the uniform graft can be taken as good as a dermatome. It's your experience. Number 2 is the advantage of Humvee's knife over the dermatome is that the graft can be wider than the dermatome. The advantage of dermatome over Humvee's knife is that if there is a contour area from where you have to take, like in burns, say from chest wall, where the ribs are there, then it is very difficult with the Humvee's knife, but the dermatome will move in the contour and we'll take the graft. So this is the advantage of dermatome over Humby's knife, and I told you the advantage of Humby's knife over dermatome. Second thing is the the roller. The roller is many times useful also, but if it tries to entangle the graft while taking, there are two ways of prevention. One is that before initiating the graft, you lubricate the donor site nicely. And the second thing is, once the graft has appeared over the roller, if one assistant who is free can hold both the edges of the graft, then there is no chance of graft going onto the roller. And the third point which I wanted to mention about the Humby's knife selection by the residents who are just passing out. You must know how to select when you are going to purchase an Humby's knife. And those specifications are extremely important. But one of them is that it should not be too heavy. Nowadays, with the variations of metals, if they are too heavy, then you don't, if you give additional pressure to that weight of your hand, then the graft becomes deeper. So the graft Humby's knife should be light, as light as possible, so that your pressure can be calibrated by yourself while harvesting the graft.
Sir,
One,
thank you. There is
one more point, one more addition. To Usmani Api, which angle you use Humby's knife, which angle you use that powered or electrical or pneumatic knife blade to the skin angle, skin surface, which angle?
Sir, for Humby's knife, the angle should be between skin to blade should be 45 degrees, sir.
Is it? Are you sure? Next team.
Should we change according to the thickness of the graft, sir?
But common.
Humby's.
Common.
Sir, between 45 to 30 degrees.
It is parallel to the skin surface.
Parallel to the skin.
Okay, the other one? Electrical or pneumatic? That is 70 degrees. We have to go like this. You cannot go parallel. So this is the main difference between these two. Over.
Thank you, sir. Any more questions from senior faculty or anyone? Otherwise, we can conclude your session, sir. Any questions from judges or any other senior faculty?
Comment from the judges.
Yeah, Dr. Bhattacharya, good evening. So just a comment from my side. Have they been conversant with all the equipment at their center, the postgraduates, or they have got a theoretical knowledge about some of them? Yeah, the candidates, have you used all these kind of dermatomes? Humby's knife, of course, you must be using the electric dermatome, drum dermatome, and other equipments.
We have used electric.
We have used
electric dermatome. We have, sir. We have used for harvesting graft from the scalp.
Okay, so you have used at least the two kind of equipments. That's fine. That's fine. Okay.